Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. And welcome to KIMEcast. Tony Mikla, Russ Dunning. We are going to do our talk today mostly on case studies. So we're going to break this up into 3 different cases and take you guys through some things that we're experiencing in the clinic. These are more challenging cases that we've come across, and go through the process of decision making and how they roll. So we'll talk one about an ACL, which should be, hopefully relatively straightforward, but in this case it was not. However, still doing fairly well, but I've got some questions. And we've got proximal humeral fracture, which again would be a very relatively consistent condition to manage. And then we'll talk about a knee condition that rests on more of an urgent situation, more of like an emergency response where the knee is locked up, and then what to do in the situation and what the next steps will probably be in that case. So it should be fun. So let's rock and roll. So I've got a young girl. This is ACL situation. So a young girl. We rehabbed one ACL just over a year ago. It was 2 years ago. She did quite well. Had surgery. I actually came to meet her because she had had surgery, gone through some basic PT, and they felt like that wasn't going to help get them back to sprinting and running and getting back onto the sport. She played soccer pretty competitively. She was 14 at the time. Pretty developed young female, and was kind of a D1 athlete stature, certainly strong and taller, and has the frame and everything else. So nonetheless, that went. I saw her at that point. I met her about 4 or 5 months post-op. We rehabbed that, got her back. She did really well for a year. Came back, and then a year later had her first practice in a team situation. Had a contact injury where she just got hit directly on the side of the knee and popped the other one.
So, other side.
Other side. Knee. Yeah, other side, unfortunately, yeah. So that was last year. She's at the point at this, we did the preoperative PT stuff, got everything going, looked great, it was easy. Then she had the surgery to get the ACL, which also was great, and that went fine. And then we started the process, which seemed pretty benign, same old, everything looked good, no big deals. But the doctor did tell her in the post-operatively that he really wanted her to work on flexion. He really wanted her to work on bending the knee quite a bit, which is not something that usually you gather or something you usually say. Usually the focus would be let's gain extension, So for no reason that was said, and that kind of I thought that was an interesting piece of information that I gathered in the first meeting. But anyways, we got to work on stuff, same old. Extension was what it usually is. We just kind of flexed to 90 and let it come from there. That really wasn't terribly difficult. We kind of got -5 degrees to 85 degrees on day 1, and then just kind of progressed it. So getting 90 was no big deal on the flexion part. Never really worried about flexion, usually don't. And then the extension was certainly a little slow to come, took a lot of effort. We were able to get it, but it was very challenging. It took us several weeks to get that. It doesn't stay till to this day. Here we are 6+ months later.
It was painful in the beginning?
It's painful, yeah. So we can get it now relatively unpainful and get it totally flat, but it comes back. It bounces back. So it's got this bounce back effect, which is super, super frustrating, super difficult. And then we have on the bend side, we were able to get it to about 85, 90. That's about all we could do. I really never kind of got past that. Really quite stiff at the end, painful as well. Anterior knee pain at that point, limiting factor. Really not much posteriorly. Still same situation. So we did that, and we got to about 2.5, 10 weeks out, 2.5 months out, almost 3 months out. And then we, get the doctor's second follow-up visit comes around that time, and elected to go ahead and do a manipulation. So doing a manipulation under anesthesia. So I've seen this a few times on some ACLs, and I've never been a big fan. I just don't feel like they really get much gain, and it seems like the question I always ask, of course, is why do we have to do a manipulation? What has gone wrong to get us at this point?
Mm-hmm.
Because this surgery in today's day and age usually is quite easy to get the range of motion back. Flexion is almost never a problem. And extension obviously creates some difficulty, but not with the right techniques. It's very consistently can get extension back as well with the right efforts. And in this case, we had trouble with both, which is
weird,
odd for an ACL, right? And so anyways, we led to the manipulation. Have you seen many of those?
No, I can't. My last ACL manipulation was 15 years ago.
Yeah.
So
it's probably best.
Yeah.
So I was not really a fan of that moving forward. Of course, I don't get to say in it, but as thinking on it as the sideline practitioner, I was like, well, it's it is what it is. It's not going to hurt, but I don't really think we're going to get much benefit out of this. And that's exactly what happened. So we had the manipulation. It was fine. We, saw her the day after right away. Actually, I may have started the same day, as a matter of fact. And it was no change,
Did they report how much motion they got?
I didn't see anything in writing, and I don't have a relationship with the doc where I can communicate with them in a free and clear manner. So this is one of the downfalls, I think, of this case, is that ability to kind of communicate and have the type of relationship to really find out what we're dealing with here. But the situation was, it didn't really make much difference. It actually was worse for about 2 weeks. And it swelled a little bit more, all of that kind of stuff, and then it kind of bounced back, kind of got us pretty stable. And then for about a month or so, it kind of just hung out to what it was before. And now we finally got it to break through. So now we can bend it about 130 degrees. So we kind of got through the 90, finally getting it to about 125, 130. But that's it. It's firm, still hurts in the front of the knee. Extensions, I can get it. It's relatively painful, but it's doable. And then it bounces back. So we're kind of this like bounce back situation on both ends of the spectrum.
5 months out now?
Yeah, we're good. We're 6. Yeah, 6. Yeah, it's really frustrating. It's not a good situation. And then strength wise, we're actually quite good. So we've been working strength the whole time in an effort to get as strong as possible. So when this thing lets go, and hoping that active control would stimulate it to let go a bit. Not enough that we've caused inflammation or inflammatory stuff. We're doing weight bearing work, but for the most part, we've progressed it. With a leg press and, all the safe things.
So obviously terminal knee extension is not really present, but she's strong through the range that's free.
Yeah, through the range is available. So testing her at 90 degrees, testing her at 60, at 30 degrees, and all those planes, she's actually equal to the right side, to the non-involved side, which is, and it's not only is it equal, but it's because you see that the idea is that the whole body gets weaker during this time, but the amount of force generated is ample considering the situation. So that's actually pretty impressive. There is some atrophy, but it's actually quite strong still. So that's not really a limiting factor, And we push that quite a bit as she's really non-painful on a daily basis now. She just doesn't extend fully when she walks, which is horrible, and she clearly can't flex.
And when you do like a simple like drawer, is it like a really stiff drawer?
Yeah, it's solid. Yeah,
it's
exactly.
Like almost overly stiff, like it just no give.
That's really it. This is exactly the feel is exactly that. So even varus and valgus isn't a whole lot of play.
Yeah.
The play is definitely down. The knee is not, it's not effused and it's not like terribly swollen, but it's just a bit of a stiff knee. I mean, you could consider it fibrotic, but it moves free enough that it doesn't seem to be fully fibrotic. So anyways, I mean, we're kind of working in the dark, I guess is my point. She's been informed, hey, it's fine. Let's keep moving forward by the doc and by that approach. They have not re-imaged it. It doesn't seem to appear like a cyclops lesion to me because it's, both directions, although that could be a factor. There's still some swelling, and then it's certainly stiff in both directions. So, I think.
But explain a little more the cyclops. The cyclops would be a portal direction. That's a directionality problem, right?
Yeah, usually we have an issue with extension, right? So we're getting, typically it's where what happens when they put in the graft, and this was more in the past than they do today, but as they put the graft in anteriorly. For it to kind of sit properly and get full knee extension, sometimes they'll have to carve out a little bit of the trochlear area between the two femoral condyles to kind of create a little more space there so that ACL can sit properly because of the way the tunnels used to be drilled. Now with the newer technology, I don't know what the doc used in this particular case, but that's usually not necessary because the way they can drill the tunnel a little more on the posterior wall and that cyclops is usually very, very rare. Plus, but if that was the case, extension would be our limiting factor exclusively.
Right, that wouldn't explain the flexion problem. But if it was an overly tight ACL.
Yeah, I think we're a little tight. I think in this situation, and I think we're going to learn from this at the end of the day, is the graft is probably a bit snug.
Yeah,
and that's why we're having such a difficult time going back and forth. And I wouldn't be surprised if that was known at the beginning. Why she was informed, let's work flexion from day one. So I think, I guess my point to this case is I don't have the solution at the moment. It's challenging. I'll certainly be open to some feedback from the group, from those listening, as to ways to try to address it and get after it. We've done everything from prolonged stretch to mobilizations to floss band work, compression work, everything you could do from a healing and swelling management standpoint, which really isn't our problem. She doesn't really swell in that way anymore. But, I think my point to this and like the reason for bringing it up is that sometimes you can do all the right stuff and go through your normal routine and, You just don't have all the information present. So my goals were twofold here. One is that to speak about the manipulation idea, when you're doing like a cartilage or a ligamentous or a anything outside of a total joint, and even at the total joint, I'm not a big MUA, manipulation under anesthesia fan, period. I don't think it's necessary, and very rarely have I seen it be really effective. I think that we have this very poor anticipation that scar tissue is limiting us. I just think that's a very easy cop-out. It's an easy excuse. It's like, oh, that's why I'm not progressing scar tissue. In 20 years, I don't know that I could ever say that scar tissue has truly been a limiting factor.
Yeah, I agree.
In range of motion progression. Yeah. I think this was something that was said back in the day and something that's kind of carried through. And especially with the newer surgical techniques, we spent 4 hours in a surgical lab with the doctor on Saturday. And the techniques that are being done now, scar tissue is not our problem. You know, the minimal invasiveness, using the arthroscopes, these different things. So now there are still problems that come from surgery that aren't perfect, and that's fine. You know, I think there's an accepted risk. You know, surgery is not going to make you perfect, like, period. We know that to be true. But I don't think that an MUA, I haven't seen that become all that effective, and I think that the blaming of that is on scar tissue is also faulty.
Completely. You know, I do use a line in this situation, quite common, and it allows everyone to have a little bit of grace for the situation. And maybe, you know, that's a weird word, but I think it can be appropriate. And I say, you know what? The good news is you're not loose. And I'd say, you know, for every failure of an ACL, 10, 11, 12, 14 months out that I've seen, for whatever reason, let's call it like maybe I can remember maybe 7 or 8 failures, and they hurt like when I think about them, because they were all female athletes around 15, 16, 17, returning back to their most loved thing in the world, and they re-tear, and it does not sit well. You remember forever when that happens. And all those cases, they were so loose that I never stretched them. That's the one memory that sticks out of it. For all the people that were insanely tight that I had to stretch the high heaven for the better part of a year and a half, I never saw them again for a re-injury. But for all the people that I never touched manually, I am worried. So that I've used that line where it's like, well, if anything, you're not loose. So this thing might just take about a year and a half to fully stretch out to make a custom fit ACL.
Exactly, and it might let go. So I think that's another great point about this case, is that's what I'm hoping for, is that we've moved forward, like we've progressed it. Strength-wise, we've continued to progress well. We've moved forward with some impact tolerance activities like quick feet, ladder drills. We're doing some light agility things. We've started running. Though all of those I realize is not great and maybe not directly in line with like protocol or what someone might consider to be best practice. But in this type of situation, if we don't do this, there's no way this knee changes. You know, the risk we're taking obviously is, you know, does it create some more arthritic issues? Maybe that she's moving on a flex knee a bit. I'll take that feedback. However, I would give the same feedback back if I don't get it straight. I promise you, she's going to have arthritis and she's never going to be able to move. So we have to get what we can get. And maybe if it stretches a little bit in the process and we get it to, you know, maybe it cracks and everything gets a little bit better. You know, so it's things to consider. You know, is that the situation is not a situation where I don't think the doc has a good option to go back in and fix something. You know, it's not like we can just go in and reverse something or debride it or clean it up. I don't think that would make the case. I don't think this is a scar tissue problem that people blame so much for. So it comes down to us and the athlete. And in this case, you know, she's all on board. She's not that painful and super motivated. She's actually excited. She's loving to do the activities. It didn't hurt to do any activities and doesn't swell, but it's definitely not ideal. But as we've done more, the knee has done better. So we've definitely had to push beyond like my normal laws would be, you know, get the range back, get the strength up to standard, and then start challenging on impact and change direction and speed. But obviously in this case, we've had to, I think we've had to move time-wise, we've had to move sooner. We had to move appropriately time-wise, but sooner than we're ready for from a real like measurement standpoint. You know?
I mean, this case sounds incredibly familiar to, I had a 5 in the world, and she was slow through her rehab. Similar, she actually had an ACL repair, which is kind of a curveball, right? And with that repair, when I first felt it, I was thinking in my head, "Damn, this sucker is tight. It's not going anywhere." And it took, I mean, I've never stretched a knee so much. She saw her chiro twice a week, me 3 times a week. So she had manual therapy done on this knee 5 days a week. And it still took about 6 months to like kind of get, I would say 95% range of motion. It was the most knee stretching I've ever done of anyone. And the was threatening us. They said, if you don't get the range of motion here, we're going to do a manipulation. And I had to fight back and say, albeit it's not fast, it's slowly happening. So I'd rather you not manipulate because we're getting micro changes and she's able to function. So I think similar to you that as soon as you can start kind of like functioning pseudo normal, the stimulus will be powerful.
Yes.
Especially if they can do it, without faulty compensation, no valgus stress. Like you look good at the movement, you just don't have full movement.
Yes, that's
and
super important.
Yeah, and we found that it just took longer than normal, but the progress was slow and steady would be like the phrase. And I think that's like whenever I think when a doctor is kind of fighting back, which kind of depends on what relationship you have.
Yeah, I think that's a great one. A good example. And I think that's exactly where we're at here. Is we're making consistent progress, although very small and very, very slow and not ideal. And we have pushed it, and as we've pushed it more, the knees responded positively. And the fact that we've started to run, do some not change of direction, but do some agility work and impact preparation work, like even some pogos and such. And of course, we're squatting and doing some deadlift work and all of the movements to get things strong. So it's going pretty well.
How much do you think, like any bone contusion or cartilage, maybe like bone pain, can kind of give you that rebound effect out of the extension? Is it like an intolerance because of where the condyles meet at full extension that maybe neuromuscularly she's just inhibited right there?
To get that, I don't know. I would say, I think that a bone contusion is a really strong concern on an ACL for sure. And I think we should expect that there be some degree of it. In my experience, I used to see it show up as the impact stuff comes on, where we start getting more impactful. Then you get a little swelling, you get a little knee effusion comes back. And then sometimes that can be slow, where you can do certain quick feed drills or ladder drills, but you can't really jump the person. Maybe that takes a month or 6 weeks to kind of get over a step that usually takes a week or two. So that's what I would expect there. But in this case, I don't know. I wouldn't suspect that. I guess my own thought process, but it's not wrong. There again, it feels more tissue based. And there is an elastic component to the stretching where we can get into the range, but it has a bounce back effect. Like it takes a long time to get it. We can get it. It holds for a moment. And then, of course, even with all the neuromuscular retraining, I mean, we're doing a ton of like terminal knee extension work, planks, terminal extension in a squat, in a deadlift, on a leg press, reverse walking, retro walking, all the things. And in an effort to try to really get that extension rocket and use it. And it looks pretty good for, the time of the session. But then by the next session, it's just, I'm sure by the next day it's like that.
I think a fantastic lesson is for every practitioner or patient out there listening, that every, typical ACL is actually atypical somehow.
Oh, yeah.
Where are you custom? Is it, the width of your hips? Is it the stability of your ankle? Are you naturally hypermobile? Did the doctor put you in a little tight? Do you have that terminal knee extension? Is there quad inhibition? There's always nuances to everyone, and if you don't appreciate how unique your case is, you're going to miss it. What's two things? You're either going to re-injure yourself, or you're never going to make it 100%.
Yeah, it's a great point. I actually think it's a quite hard diagnosis and a quite hard rehab. Even though there's very standardized things to do, and everyone's researched it to the moon. You're right. No, none of them are the same. No, at all. No. And what are you trying to do? What sport are you trying to go back to? What position do you play? What's your style of play? All those things have huge impacts. And then, of course, how did you heal and all that kind of stuff. I think the questions are probably less about what they commonly are asking about, like what graph should I use or how many months out am I? Like those aren't that important of questions. No. In comparison to how well did you heal as a whole? Completely. How strong are you?
Was it non-contact contact? If it was non-contact, what are the issues that contributed to that? When you look at the protocol, and let's just say there's like 100 exercises in a protocol that lasts 16 weeks. Not every person should be doing 3 sets of 10 of all 100 exercises. That's it. Is each person actually has their own issue, and they should be putting a lot more emphasis on the cluster of drills that treat that. Whether it's how the hip rotates, it's how the foot stabilizes. Is it distal quad? Maybe they're just low on hamstrings. You got to get the posterior line going. Or they have a shitty core, and you got to really like focus on the stabilizing effect, with some get-ups and some perturbance with single arm loading. You don't know what that angle of rehab needs to be and really until you appreciate the whole body and the story that brought you here. So just treating ACL, if ever someone says like, oh, it's kind of easy, you're full of shit. You don't know what you're doing. Yeah. I would go the other direction. Here's the protocol. Let's do this. F that, I'm out.
Exactly. It is a straightforward process, but there's going to be some variance in the process that you're going to have to adapt to. You're going to have to account for. I love that perspective. It's great. Like there'll be times where some people just have a difficult time building strength, and you're going to have to load them much longer than you think you should have to. And there'll be other people who build strength super easy and fast. Yeah. But might have a difficult time with impact, or might have a difficult time with speed, or stopping, or cutting left or right, or whatever. It's really a dynamic structure. It's a tough go.
Yeah, we were talking about this with the doctor over the weekend. Every ACL, you should be looking at the op report and figure out, or at least from a trauma standpoint, what makes you unique. Then you look at the DNA, what makes you unique. Then you look at the mechanism of injury, what makes you unique. You have to find that variance of what makes you unique, and without it, you're lost. You don't know what you're doing.
Yeah, I like it. So I'll keep you guys posted on this outcome and where we end up landing, but I wanted to share that as a case example of something that's certainly not easy, but it's the idea of using things we've talked about, like a sports medicine mindset as to what's best practice for this person based on what we know we have to work with. In this case, there's just not a lot of other medical support to get. An injection doesn't really help us in any way. Some sort of like a sample of like a drain in the joint doesn't help us in any way. More surgery doesn't really help us in any way. We got to kind of just work through it together and kind of stick to the paces and be okay that the protocol doesn't match anymore and the timelines don't quite match anymore. And we have to understand what is the limiting factor. In this case, it's certainly stiffness. It's no longer strength, and impact is no longer a factor either. So it's a matter of like, all right, let's get this thing moving, and then we can really use it in its full range. So I'll keep you posted.
Yeah. Every PT listening should start challenging their own caseload and say, what am I missing for my post-op patients? Am I just running a protocol, or am I appreciating what makes them unique? We should be thinking.
Absolutely. That's the ultimate message, and the purpose of this section of the podcast is to have that frame of mind where you're a thinker. Like that's something we pride ourselves on, and our clinicians is that we're going to think, and we're not going to run a protocol just to say that we ran the protocol, but we're going to look at we're going to think through the problem. We're going to think through what presents in front of us, how the patient is, and then understand the condition and understand how fast we can progress them, and everything matters. And so we gotta be there, and that's why it's a one-on-one appointment, because you have to intervene. Yeah. So why don't you go next with your exciting case here?
Yeah, well, it goes to the knee again, but it's quite the opposite issue. Hopefully, it's the opposite issue of what you just presented. So I have a 30-year-old elite athlete. He plays for a league. I shouldn't get too many details here. Nonetheless, he showed up on Friday, and he had his complaint was, hey, I was coming out of a lunge. I was just kind of getting up, and my knee tweaked. It kind of gave out on me. That was the phrase, gave out on me. And he said, it hurts pretty good. I can't like bend it all the way, and it feels tight. Like, all right, come on in. Let's check it out. So I do ligament testings, and it all checks out fine. I flex him about 130 degrees, and he has some pressure in the knee. Doesn't like it. I palpate on the lateral aspect, and he's like, yeah, it's right there. If I push really hard laterally, basically kind of right at the LCL, he's like, it hurts right at that spot. So I did palpate pretty hard, and it was painful with joint line tenderness. And he's like, do you think my IT band or my ligaments kind of popping over? Because it felt like something was popping. I don't know. But right now he had like pseudo normal range of motion without much stress through it. Being 24 hours from the mechanism, I wanted to just kind of play it safe, going to be nice. After I did my ligament test, I was like, you know what? Let's just spend the weekend. I want you just to do some easy bike riding, not a lot of stress. I want to see you on Monday after the inflammation passes, and I'll check you out then. So he came in Monday morning. He's like, I feel great, Russ. He has an event in a few weeks, so it's very important that he feels great. But I feel great. I'm like, okay, let's check it out. So I straighten it, push it straight, no problem. I do a varus valgus, no problem. I do a drawer, no problem. I do a deep knee bend. And he's like, he kind of winces. He's like, I kind of don't like that. I'm like, So I put him in a Faber test and kind of tug at the LCL. And I kind of palpate at the LCL. I'm like, is it tender through there? He's like, that's kind of where it's at, but it feels fine when you touch it like that. I'm like, okay, can you grab your own ankle and hug it? So kind of do like a piriformis stretch. Mm-hmm. And he does it. He's like, that feels fine. And then I give him just like a little bit of overpressure in the piriformis stretch. And the whole thing locks. I'm like, oh, crap. So he's in excruciating pain. The knee's bent at 90 degrees. He's in like a hook-like position, and the knee won't budge. And everything's like in spasm, and he's like thriving in pain. I'm like, oh, crap. So I'm like, can you straighten it? He goes, no, I can't. It's completely locked. So I kind of put my fingers underneath the crease, and I give him some gentle distraction. And then with my distracting the knee, he's able to straighten it out. And around, with the knee bent about like 45 degrees, I hear and feel a pretty gnarly clunk. And then he finally breathes because he was holding his breath that entire time. And this guy's probably
That's exciting.
He's probably single-handedly the toughest man I know, and he was just like in excruciating pain. And then afterwards, I looked at him like, "You okay?" He goes, "Yeah, I'm okay now." And like, "Can you stand up?" And he stood up, bounced around a few times, did a few squats. He's like, "Yeah, I'm fine." So it went from like death-defying, like severe pain, traction, bent the knee, clunk. Okay, now I'm good to go.
It's so amazing, like that true kind of locking of the knee situation.
Yeah,
I had this kid, and this is very rare that I think you get this in a PT environment. So I had this kid who was training for the NFL Combine, and he was training on the turf field, like 100 yards from our treatment area, and he went down, twisted on it. Was making a cut, twisted on it, went down, and same thing. Says knees locked, couldn't move. But he wasn't locked quite that far. He was locked at probably like 60 degrees flexion. Mm-hmm. So he was carried in by two other big football kids, bring him in, put him on the table, and he's like just sitting there, and he just hurts a little bit, but it wasn't bad, but he couldn't move anything. And I was like, God, this is it. This is the meniscus like locking situation. I'm like, So what do we do? We got 3 weeks to the combine. How are we gonna what do we do in this situation? Do we go the doctor route and all this stuff? So anyways, I started playing with it, and he was sitting there in open change trying to like rock it back and forth. It doesn't really move much of anything, and then I tractioned it and then gave a little rock, and then same thing and kind of gave. It's like, and it's like, and then he's like, oh, that was amazing. and then all of a sudden it's like, whoop, like you move it no problem, And I was like, he's like, oh, it's so much better. He's like kicking it. He's like, yes, I'm good. I'm like, that was awesome. I was like, that was like textbook.
Yeah.
And then I tested everything out at that point again, and all, like I said, all unstable. And
Did he compete?
Yeah. So that in that approach, same situation. We he couldn't believe it, so he's hopped up. These guys are so gnarly. Like he couldn't walk a second ago. Boom, pops up, squats, tries to run on it. Does a few jumps. He's like, dude, it's fine. I'm like, okay, that's not true.
Yeah.
I'm like, this is a meniscus. This is definitely a meniscus. Most likely a bucket handle. Like you're gonna be. This is not necessarily a good thing. You're going to be extremely vulnerable to cutting and changing direction and pivoting. But linear stuff, you're probably going to do just fine. If you keep things going straight ahead, you just can't be able to make cuts. And then at that point, he disclosed that he'd had some stuff in the past as well. It wasn't the first time. And rotations always giving him some trouble, this, that, and the other. So
did he perform well?
Yeah. So he ended up going to the combine, did well. He was able to sustain the thing fine. Now the combine's different because you're not really like competing in a live event where you have to go against a live defense. So he didn't have to have the reaction capability, which would have put him at some risk. We probably would have braced him if we were going back into like a game situation where he's going to be in like a higher risk, like deep knee bend rotational situation. But yeah, he ended up doing well. And the conversation at the time was like, well, see what you got. If it happens again, they're probably going to take you to surgery. And I said, that's what you're looking at anyway. So do you want to go now, or do you want to, wait till after the combine and see what happens and then have it done? So he elected to go ahead and continue to compete, and he did fairly well. His 3-coner and his pro agility were a little bit slower because he was a little hesitant with those, but it was fine.
Well, right now we're kind of right in the midst of that decision making. I was, on the phone with, quite a few people this morning on how to handle this, and it's a common pathway. It's like, well, we can kind of do nothing, hope for the best. We can have injection support. Injection support could be multitude. If you have time on your side, then PRP, stem cell injection, growth factor are being done more and more for meniscus tears. Not from like I don't necessarily think that the meniscus is stitching together. Maybe there's some proof in that, but it's more or less just kind of help the synovial fluids, the synovium in general, and perhaps the meniscus quality kind of return back to homeostasis, so to speak.
yeah.
So I think
Decrease the swelling, increase the pliability of the
Right.
tissue. Yeah.
right. So I'm seeing a lot of people kind of opt for the PRP injections for a meniscus tear in this way, or which I'm equally seeing just as much is do a cortisone shot, and then 6 weeks later do a biologic like a PRP or a stem cell, and especially if they're a little bit sensitive on timing, they want a reduction of pain in the near future. This idea of like kind of flipping the script of like, let's do an anti-inflammatory medication, and then 6 weeks later after it's dissipated, now see if we can encourage some healing. So I'm
That's
seeing
interesting. That's obviously pretty strongly
it's
considered
weird.
the wrong way to go, right?
Completely, yeah. It's like,
once you do cortisone, don't do any other procedure, surgical or anything for at least 3 months, right?
Yeah. I have one of the best hip surgeons in the world kind of say that specifically. Like, hey, we'll try this, and then 6 weeks later do that, and so it is all over the map in terms of how you do these injections, but really conservative treatment, injection support, and then surgery, and obviously surgery being the last resort. But
Yeah. Obviously, size of the tear matters, and frequency of this type of problem. If it's only in a deep motion, then maybe it's it's a tolerable thing to play in the meantime.
Yeah.
But if that's a motion they need and they're going to be in, and it's clearly happening with regularity, it's kind of like a shoulder dislocation in football, right? It's like, well, do you deal with it and let it happen a few times to finish your season out, or because surgery is going to be the fix for that. Or do you stop your season and do it now? There's so many variables there. Yeah, and I think with with elite sports, there's always money on the line. So
yeah, it's their job, and so when it is your job to do something with your body and make it perform, you have to appreciate what's it worth to you.
That being said, I think it'll be interesting in college with money on the line now with these college athletes, like how that changes the decision making process.
Absolutely,
that's a really sensitive space in pro sports where do you go to the team doc? Do you go get your own opinion? Do you stay in the system?
Yeah.
Feel like maybe it's not in your best interest in mind, so they want to get third, second, third, fourth opinions.
Yeah. Another word for interest is incentive. Where is the incentive? The incentive of the coach is different than the the head of the school, the leadership, the booster club.
Yeah.
The next team that wants you. Oh, there's built-in incentives, and they're in conflict.
Yeah. Unfortunately, the truth is, if they've been doing it for 10 years, that means there's been 1,000 athletes that have come through, and you'd be one of them. Whereas for you, it's 1-1. It's N of one.
Yeah,
right?
you're going to care more about you than anyone else, maybe except for your mommy. It's
So it's a big deal. That'd be interesting to see how that goes.
Yeah,
it happened to just this morning.
Just this morning, I know. Yeah, and the problem is, it's like as a PT, we're not often in a space where our special test is going to show itself in such a positive way that it's kind of debilitating. You kind of hate doing that. You hate exposing a person. I hated doing it.
Yeah.
It's like one of those weird things. Like, I kind of regret doing it, and then I don't, because I need him to know it's there. So you need to be mindful that when your knee goes into this rotated position, bad things can happen. So now he knows. He didn't know that. Now he knows. Well, I just put it in and put it out. Kind of easy. So whether or not you manage conservatively or not, the position to avoid.
Yeah. There's wins in that for sure. Especially since the recovery on that one's so quick as far as come out of it and how good they feel, like almost right away.
Yeah.
Assuming it doesn't get too swollen or create a new effusion or something, but even then you could probably control it pretty quickly.
You probably count on your hand how many special tests that can be positive with your hands right there, that you don't want to you expose the problem. You don't want to dislocate a shoulder just because you can dislocate.
Yeah.
You kind of have to, like, hey, let's test this multi-directional instability. Yeah, we got some play. This shoulder probably can go.
Yeah.
You just because you don't make it go.
Yep. Yeah.
So it's rare to be that.
Yeah, but I think for us it certainly is rare. I think for the doc it's not so rare, And I think for an orthopedic surgeon, I've seen many guys dislocate somebody's shoulder in front of me, and I've certainly seen them try to take a knee and really crank it, and it's because they know they can fix it, right? So it's a totally different mindset of, I know that I have the tools to fix this afterwards, and if I have to, we will. But he has to make a decision that this is the right choice, And I think in our case, much more on the conservative side of that equation, where
Mm-hmm.
we're not the guy fixing those problems. We're just helping the process after it gets fixed, after the surgery. So something to consider. But if you are in the area of sports med where you're on the field, you're on the sideline, and you might see some of these things. I will say that's a very consistent, like, textbook meniscus experience that I've seen, and a little traction is really, really nice.
It's,
A little traction
you know,
makes a big,
yeah,
big
it definitely
difference.
you have to think on your toes in those moments. Whether it's a shoulder or a knee. I know Jonathan, he hip dislocated in front of him. I've never seen a hip dislocate.
Yeah, no, it's a
but
rare
it's kind of like, what do you do in that moment if you haven't at least looked a little bit into the top 5 sports medicine injuries that can happen right on your table or in the weight room? You might be called to action to relocate a shoulder, relocate an elbow, relocate a knee.
Yeah.
To relocate a meniscus in this place.
Yeah, you can see. Sometimes you'll see it with the patella as well. Like they see a subluxing patella is a common thing that we'll see in the clinic. And
Yeah.
if you start doing some cutting work, it can come out. So
Yeah. I've been following, what's his name? Our CPR guy. What's his name? Why is his
Ethan.
name? Ethan.
Yeah.
I follow him online. Do you follow him online? Black belt,
yeah. Ethan Kleinsworth. Yeah.
black belt athletic training, black belt.
Yeah. He does all the jiu-jitsu stuff down in LA.
He shows all of his like real-time relocations. It is nuts. He was showing an elbow, then he was showing, like, he's just doing it, like, I feel like every weekend he's putting body parts back together. It's insane. If you want to follow someone online, follow Ethan Kreisworth, right?
Yeah, Kleinsworth, yeah. That's it. He does. Yeah, he has too many videos of relocations.
I know.
But in jiu-jitsu, hey.
I know, it makes me a little tentative about competing. I'm like, I don't know. Watching
As
his,
you should be
yeah, as
tentative.
I should. It's
Yeah, when the goal is to tear someone's ACL and dislocate the shoulder.
yeah, well, that's gonna happen sometimes.
Yeah, unfortunately, that's the intention of the skill set. Okay, I got one more for you. This two just came across today, so they're just fresh and right in time. So in this case, this was a new patient today. This person has a proximal humeral fracture, so they're a little bit older than Medicare patient, like 66, 67, and the fracture happened 8 weeks ago. Was on a deck, like on a platform. I took a step backwards, and the platform wasn't there anymore. So it was the edge of it. Took a step backwards, ended up falling, reached out, broke other things in the body, but broke the humerus to try to stabilize the fall. So that's done fine. 8 weeks, in a sling for a little while, and now she's kind of by her side, and she has very little to no external rotation, and she can raise it very slightly or sideways very slightly. So I mean, it's basically like in a sling still, but it's technically not. Pain level's not bad. Her worst side of pain is like a 1 out of 10 at this point. So we're 8 weeks out. X-ray was done last week, confirmed that the tissue is healed, was the statement that was made to her around the X-ray. So much improved, stable. And then, so in the clinic today, the focus, of course, was, how did we get here? What's the subjective? And then what are we doing? So we went through range of motion work, and it was tough to get to 90, but it got to 90 on the first day. We're not a big pain practice, so I just want to comment here that if you're ranging the body in a physical therapy environment, if you're causing pain, there should be a very, very good reason for that. And you should know exactly why and exactly when, and you should have very, very good proof that this is why you're doing it. Pain, in my opinion, is very, very unnecessary in the body to gain range of motion. I think that probably 95% of people's range of motion deficits are due to neurological factors. And when they are due, as we were talking about the young lady earlier with the ACL, I can stretch the crap out of it. And it's really not that painful. So that one is mechanically stiff. I also think there's neurological components, and it's not that painful. But back to the topic at hand is, if you're having to really force the range of motion, you're doing it wrong. The range of motion should be relatively easy to get. This is one of the most difficult ranges to get, is on a proximal humeral fracture. But if you had a post-operative condition, getting range is tough. That really should not be the case. So we're mostly a pain-free environment type of a treatment approach in clinic. I just don't think it's necessary. So anyways, got her to 90 degrees relatively easily. Abduction was a lot less, more like 45, 50. And external rotation was a real bear. It was really tough to get more than 5 to 10. So nonetheless, got her started with some stuff. But the thing I really wanted to talk about was the recommendation. So comes with a protocol, and well, not the protocol, but a prescription from the doc that says no, no strengthening and no active range of motion. So our therapists working in the environment here are like, what do we do? And what do I do with this? Like obviously I can do passive range, of course. We could do, we could do like a table slide or do like a prayer type stretch with the arm extended on like on a surface like at the table or a bench of some kind. But everything else becomes like active assisted, like the pulley's kind of active assisted. If you do some type of
stick,
a stick's not going to work. It can't even get 90 degrees, so we're not even at stick level. But we need some movement in the arm. Like if we don't move the limb, it's going to get way worse, right? If it's not already what we consider frozen, it's certainly going to be. So they found themselves in a position like, I want to move it more. The person's not in pain. They've got an X-ray that shows that it's healed, yet the recommendations are that we can't do any active range of motion until 16 weeks. So then it comes down to science, right? So there's two things here. It's like, okay, what's the science behind that? Is there some sort of evidence that suggests that that's the best practice, that we should not move the limb and it needs more time to stabilize and heal? And just goes back to, what we've learned over the last 50 years is that that's not really consistent in the evidence that I've seen and read and am aware of. Is that we've moved much, much further away from immobilization. Although for certain time periods it's critical, and a broken bone being one of those, that you should immobilize for a few weeks to let things heal up, establish the healing process, and then go. But in this case, I feel like we're kind of stuck between a rock and a hard place. We're being recommended, hey, don't do anything for 16 weeks, but yet, here's someone who's, can hardly move it at all. Like, how much could they hurt themselves? Like, they can hardly move the darn thing. You know what I mean? Like, let's let it go. Like, at least to 90. Like, let's get some movement.
Yeah. I think the phrase that comes to mind is you have to get DNA expression. And you only express DNA with an appropriate amount of stress. In other words, in the absence of stress, tissue everywhere starts dying, starts degrading, starts becoming more unhealthy, less pliable, more stiff, less muscle, poor nervous system. You degrade without any stress.
I think that's an important concept. It's not that nothing happens when you're mobilized. It's that you actually degrade.
You degrade.
You get worse.
Yeah. So and that's why whenever we see people like, let's get some isometrics in. Let's do some distal movement. Let's do some proximal movement. You gotta awaken the body to some degree to get, again, some expression of DNA, whether it's the muscle, collagen, tendon, fascia, ligament, bone. You have to stimulate. That reminded me of a research study I was going to share. But you have to have some type of appropriate stress. So then the question that we have to do is say, what is an appropriate stress that helps signal the right DNA expression without inflaming you chronically? And I think that's like kind of the key thing is when people are looking for these rules, how do I engage in this rehab, and what tells me I'm doing the wrong thing? And if we engage in activity that chronically inflames it, and I ask a simple question, how'd you sleep last night? Because if ever you've had a severe injury, you're not sleeping well that night because it's throbbing. That's the best indication of what inflammation should feel like.
When you have pain at night, you're likely in an inflamed state.
An inflamed state.
And it could be chronic or acute.
Did you wake up at 2 a.m. or not? Are you taking Advil or not? Is it throbbing right now at rest or not? I think there's a plethora of questions that kind of give us an idea of your inflamed state. And I think that it creates a really nice a rule set for how to engage in this therapy. We want DNA expression without creating chronic inflammation.
100%. That's everybody's protocol.
Yeah.
That's what it should be.
Yeah, that's what it should be. So what exercise should I do? Well, if you did it, how was it? Oh, it felt fine. Were you sore afterwards? Maybe only for 2 hours, but then I was fine. We're good to go. That's called DNA expression. Let's keep doing that.
Yeah, challenge the tissue to adapt, but not so much that you create an inflammatory environment or an overly inflamed environment.
Yeah, I have yet to hear of someone actually injuring themselves during some type of protocol where they listened to that principle, yet somehow the tissue ripped apart because they did a light progressive exercise, very slow, and then one day like, oh yeah, just popped right off. The only time it like pops right off, you do something fast and explosive way before you should have. Like 8 weeks out of an Achilles repair, and you decide to jump. I had one of those, by the way. Like, oh, that will pop it. So if you do something fast and powerful well ahead of time, that would pop it. But if you do something light and slow and progressive, well, that's called just great DNA expression. The body adapts to that.
Yeah. On the Achilles front, I have somebody who was 8 weeks out and they went wake surfing.
Oh, game on.
Yeah. They could barely walk and they're out wake surfing.
That's ballsy.
I just wonder how they got to that state that this seems like it'd be safe.
Yeah.
Like, really?
Yeah, that's on the border of stupidity. Like, really? That was a strong investment you just got done doing.
You just got out of the boot at 6 weeks. We're at like 8, and you're not even supposed to be in the water, probably. From an infection standpoint, you still got some scabs there on that incision. Like, and you're going into like. Yeah, it's like, oh my gosh.
It's the most important part across any program we put together. The most important part is what are the benchmarks for success, and then that tells us, okay, we want DNA expression, which is progressive overload. That's appropriate, and then we establish benchmarks so that we get to say, don't do that before you hit this. That's called safe. Don't jump before you're able to do 10 single leg calf raises. Or for this humeral head, don't play basketball, which allows you to, like, you might fall in the arm if you go skiing or you do something aggressive. So I don't want you falling unless you're able to do some planking or 5 push-ups or doing like a side plank. We need to get to that sort of strength before. But with that, the benchmarking system that helps us navigate the journey. And then we have to lean on science. No matter what protocol we're talking about, we have to look at timeline, tissue, and progressive overload.
Yeah, it's really quite a simple thing. So it's great as a new clinician, to look at protocols and look at timelines and see like a flow. I think is really, really important. But what you just said is really the science behind why that flow exists. So you really got to pay attention to, like, even if the protocol says do this and then they get really flared up, well, then it was too much for that person in that situation, right? So you got to figure out what the trigger was and back it off. And in this case, it's kind of the opposite scenario where we have no stimulus. The person hasn't been doing anything. They have very little to no pain. They're not up at night. But they have no motion. And if we don't start to get it, it's going to be just exponentially more difficult as time continues to go on.
Yeah.
And we have, what risk are we causing to the tissue to get it to move now? Like, bone is going to be at 8 weeks, if it's there at all.
Yeah.
And if it shows up in X-ray, just doing some range of motion and lifting the weight of your own arm isn't going to
break the bone. Yeah.
And
we're not that frail.
It's just going to fortify it. Yeah. Because if we don't put load through the bone's not going to get stronger either, right? So then we put somebody in a really vulnerable spot. You get out at 4 months out, and you're finally able to start doing some stuff, but you haven't done anything in a while, but you think you're free and good to go. That's when you're really at risk to hurt yourself further.
Yeah, I think at a certain age, too, you really have to be mindful of sarcopenia. If you're getting into your 50s and you kiss goodbye too much muscle, you might not ever get it back.
Yeah, good
in the
point.
rest of your life, you might not get it back. I mean, that's like, isn't that a crazy thing that, if you're 58 and you don't move your muscle for 5 months, it might be so bad you never get it back for the rest of your life.
Yeah, it's typically quite hard to target it. I think you're absolutely right. And then thinking about, like, obviously we're talking about the bone being that this is a fracture case, but you have your rotator cuff and all the supportive musculature there.
Yeah.
That cuff hasn't done anything in at least 8 weeks. Nothing.
Yeah, and you're digging yourself a hole it's impossible to get out of.
Yeah, I mean, right now we're looking at least a 6-month process just to get it back to like decency.
Yeah, the last stat I heard on this was the factor of losing muscle and then gaining muscle is a factor of 8, meaning if you don't move at all for 1 week, it's probably going to take you about 8 weeks to get that back. Multiply it by 8. Imagine if you're out for 4 months. Multiply 4 months by 8. That's a year and a half. That and I think there is some diminishing returns there. Meaning, I think the further down the hole you get, you might not ever get it back. I mean, that's kind of where I'm at. But hopefully you only kiss it goodbye for 2 or 3 weeks. And let's get some isometrics in because we have ways of mitigating the loss and atrophy. And if you lost muscle, it means you also lost tendon, you also lost ligament because it is guided by mTOR. That it's not like you can if you do one exercise, it affects the sarcomere, but not any collagenous structure. This system is a system for a reason. Muscle, tendon, joint, it's a system.
Absolutely. It functions together. And movement, we know, drives it. Like, this is great. And with all the stem cell research and with looking at the tendon research and stuff we've been looking at, all the science guys that aren't really dealing with real people and they're dealing with rats or whatever, they're all finding that even after like an Achilles repair on a rat or whatever the comparable tissue is that they'd be using, if they don't load them right away, the outcome of the rat is different than the person who gets loaded right away. Mm-hmm. So they do a surgery on both of them. One, they start loading on week 1. One, they immobilize for 6 weeks. The week 1 one does better.
Every time.
Yeah.
With smart loading. Smart loading.
Smart, yeah.
Appropriate loading.
Not jumping,
not jumping.
Starting to put some isometric tension and some load to the tissue, because what we've seen is that like you said with DNA expression, if you place stem cells into a tissue and then you don't do anything to the tissue, stem cells migrate. They either move out of the way, they go somewhere else, they get reabsorbed, they digest it out, and they don't do anything. But if you put a stem cell in tissue and then you have that tissue do something, whether it be in muscle, in tendon, in bone, in some other organ, whatever it is, if you get the function going, then the whole goal of a stem cell is to become the cell that it's in, right? To become its neighboring cells. But if you don't ask it to do anything, it doesn't even know where it's at. It's like,
Completely.
there's no communication. There's nothing for it to do.
I love
So it just goes away.
the simplicity when we had Johnny Owens come out and give the wonderful talk about Owen science recovery and all this on everything that he speaks of. The litany of research that he goes into on muscle, tendon, ligament, joint, and I love how simple he said it. It's all about loading. That's it. This whole game is about loading
Loading and protein.
Yeah, I love the simplicity of which he attacked the entire industry. I would say that there is like the neuromuscular component and balance and how you pattern.
Oh, for sure.
So I think that's the other half of the equation. But what he speaks to is like really simple. You have to understand loading, and which is understanding programming, which is understanding tissue adaptation.
Yep.
If you know that science, you can navigate your way through any protocol.
100%. Yeah, I think the protocol value often comes down to just having ideas as to either what exercises to do or what timelines not to violate. But get yourself comfortable with tissue healing. As we've spoken before here, it's so important that you understand the steps of tissue healing and understand time frames and then understand the signs of them.
Yep.
Looking for those inflammatory signs, looking for signs of different types of like stiffness or that the muscle just isn't responding as well as you'd like it to.
Yeah, and across every, at least acute injury or definitely post-operative, within the first, 4 to 6 weeks, there's something that's the most threatening on whenever the doctor reconstructed. So you have to understand that, which is why you have to read op reports, understanding which tissue was fixated or approximated, and know that if you violently do that motion, you compromise that. So I think, no matter what body part we're talking about, there's kind of like that one motion, like, oh, be mindful there. You respect that for 6 weeks. But other than that, we have some DNA expression to do.
Absolutely. The one other thing I want to just finish up with this one on is the result of this. It comes down to like obviously getting on the same page with the doc. So calling the doc, connecting with the doc, and understanding, is there something we're missing? When we first thought about this, like maybe the fracture is in such a location that it's best not to push it, or maybe the fracture is going through the cartilage surface of the humeral head, and therefore the joint is at risk, and we shouldn't push it. And my take on that is, if that was the case, then we would probably get a much more detailed prescription that comes through with like lots of details about, hey, like this is the situation, go slow, da 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 da. Usually it's very clear. In this case, it was not. It was like proximal humeral fracture. Don't strengthen, don't do active range. That's it. It's like that's not quite the full story. It sounds like to me. So we got to get on the same page. So we got to get a call, at least get to a text message position. But I can't emphasize this enough, to get to know your docs and work very closely with your docs. I think in your case today, knowing the docs we know, we were able to get a lot of people involved very, very quickly to get that solution moving in the right direction. And with the 2 cases I presented today, both of those are a little bit gray, because in neither case do we have a really close relationship with the doctor. So it's a great opportunity for us to improve those doctor relationships, get a little tighter, get closer, understand their perspective, what they're seeing, and what may have been going on there is really, really important. So I just want to emphasize that, like you can't get a tight enough circle with your docs, with your chiropractors, with your massage therapists, with your supporting cast. It's so helpful, so critical for the patient outcome at the end of the day. I just don't think you can do a great job if you don't have that information.
Every physical therapist is better with a great relationship with the other medical providers, namely the physician, the orthopedist, the injection doctor. The stronger that relationship is, you become better in the process. It's that simple.
Yeah, you have, and then you have to understand like what they can do and the leverages they have, things they can pull. You start to really see how the whole thing works together as a unit. It's been multiple times in the last couple of months that some of our clinicians have been like, oh, I got to call the doc and I want to send this person back to the doc. And those have resulted in me asking more questions like, what do you want the doctor to do? Mm-hmm. I'm not saying it's a bad idea. Call the doc, by all means, get on the same page. But what are you asking for? Mm-hmm. Be very, very clear. What is it that you're after? Well, I want the doc to know. Okay, good. Then call him and tell him.
Yeah.
The doctor doesn't have to see the patient.
Yeah.
Like,
update.
Yeah, just let them know, like, hey, this is what I'm seeing. This is what I'm concerned about. I want you to be aware of it. And they'll say, yep, go ahead, go for it, push it. Or they'd be like, ooh, Grant, I didn't know that was the situation. Let's get him in right away. I want to see him tonight. Send him to me right away.
That's right.
Or if you've got like an incision situation or a potential infection, immediately they usually want to see a picture or see the patient immediately. Or a lot of times they don't even ask. They just start antibiotics right away. I'll send it in right now.
Yeah.
So that relationship is so critical and so welcome by every person I know that does a good job.
That does a good job.
Yeah.
That's it.
If the doctor doesn't want to talk to you, then you probably should just try not to see that person's patients anymore, honestly.
Yeah, it's not a good team.
It's
because if you're not a good team.
Yeah, it's the wrong intentions.
Yeah.
It's you can't really push forward and the way that we would suggest you push forward to practice without having those types of relationships.
Yeah. Ultimately, the medical providers that people choose, it is their choice. Now, sometimes it's guided by money or what insurance is offered by their work, but it inevitably comes down to choice. Yep. And likewise, we choose our teammates too.
Yeah. That's how we found ourselves in this situation, is that these patients have found us because they want something very good. They want the best for what they're doing, which we commend them for, and it's fantastic. And it puts us in a great position where, like, man, I don't know your doctor, but I'll reach out to him and get to know him. But then we have to go back through this like very extensive process of calling the office, getting a doctor call us back. That's going to be a 2-week deal, if ever, And so the tighter you get with your docs and your referring providers and develop this really nice bond, I think is good. And it's critical. It really changes the game.
Absolutely.
All right, I hope you guys enjoyed some of those cases and just talking shop with like what we do every day and some of the grind of what goes on in the clinic. Our goal is to shed some light on that for you in these sessions, so that you can hopefully glean something from what we talked about, and maybe share it with your own inside your own practice and use it on a regular basis. So if you have any questions, want some clarity, have some recommendations for us, we're obviously more than interested in taking those and hearing that. So comment in the comment section, hit us up, DM, whatever you like, so that we can hear that and maybe share it. If you have a case you'd like to present or you'd like us to discuss, then by all means share that case. Obviously, we don't want any HIPAA violating information, so just give us some generals on it, and we could take a dive into how we'd approach it, what types of things we'd look for. So thank you guys for listening on this case study presentation portion of KIMEcast. We'll catch you on the next one.